sleep. Sleep is a big issue. And non-pharmacologic management should be used as much as possible because the research that we have on using medications isn't that great. So, first of all, as I mentioned previously, there's such a high percentage of people after a head injury that have subsequent primary sleep disorders. People should just be sent in for a sleep study. Because if they require anything from a primary sleep disorder standpoint, that is where it will be determined. And if they have a history of a sleep disorder, send them in for a new one because things change. After that, when you're looking at sleep, biggest things. First of all, environmental. Somebody's like, well, I can't sleep. Well, how do you try to get to sleep? Well, about 8 o'clock, I'm laying in my bed playing my Xbox, pick a game, that has a whole bunch of, and that's what they're doing. Drinking my Monster, and I just can't get to sleep. And, and I'm like, well, let's try these things first. So, just simple things, like the common sense things that, aren't that common, like not drinking caffeine afternoon. Making sure, and I'll tell people, your bed is for sleep and sex only. You should not be sitting in there reading in a book. You should not be sitting in there watching television. You should not be sitting in there, playing games or doing whatever, because then your body sees it as a place of wakefulness. So if you are laying in your bed and you cannot sleep, get out of your bed to read that book to try to wind down. Don't just remain in bed doing these activities. Make sure you're getting sunlight during the day at some point. This is Alaska, that's a big deal. Make sure that you're at least getting exposure so that your body knows when it is light and when it is dark. The other piece is treating the fatigue. I have people that have much improved sleep when they start amantadine because their body is fully awake during the day, therefore it knows how to go to sleep at night. And then working with different therapies. We have good research behind cognitive behavioral therapy for sleep management, and neurofeedback works very well for sleep management. Yes?
I don't know what neurofeedback is.
Because it's awesome.
Because I'm from the food office.
Neurofeedback is type I do, it's symptom-based. You don't care about diagnosis, just symptoms. It's placing sensors on the head, recording your magnetic, the electric brainwaves in there, and you're watching an image, so the brain is training itself to self-regulate. If you need videos, there's several on my website, alaskaneurofeedback.com. It works phenomenal with sleep and migraines. My colleagues, we got about 90% success rate on migraines. I've only had one person I can't fix. And the new thing we just got done with sleep and finished the FDA approval of it. It's called a Somni Resonator. I have it. It's a little box, 20 minutes, push it, knocks you out, you wake up, hit it again. That just came out. I'll update the website eventually, put it on. It's too complicated. I won't take time on that. The neurofeedback is great for self-regulation.
Do you want to come to Fairbanks?
So he works a lot with he provides neurofeedback here in Anchorage. Works with a lot of my patients in Anchorage. We do have neurofeedback providers here and in the Valley. And for sleep, mood, cognitive, as well as just for PTSD and not just migraine, I found it also worked well, just general pain symptoms. I really do like neurofeedback. And so that when you hear me speaking about it a lot, it's because I use it a lot. I just consider it as one of my primary therapies. When I'm thinking PTOT speech, I'm thinking neurofeedback.
Can he put
Most do.
Can you put your website up on
Can you put your website on the board?
Okay.
It'll be there by lunch.
All right.
And you just type in neurofeedback Alaska, I'm like the top 6.
Yeah. And we have more research coming out on that as well for brain injury specific stuff, but there's an entire chapter we dedicate to it in our book. Neurofeedback, we've just found it works very, very well. So, the bottom line that comes from the Academy is that if you've tried everything else and all has failed, including looking for primary sleep disorder, then, well, melatonin supplementation, try that because it's not going to hurt. Or trazodone, because we found that it doesn't really cause that much issue, including which it doesn't really work that well for sleep. So and melatonin really only works well if it is a circadian rhythm disorder. Up here, it does work very well, and I have a lot of patients that I'll just say, around the equinox, spring and autumn, just use it the week before and the week of, just to kind of regulate yourself, knowing that our sunlight and nighttime cycles are so strange up here. But otherwise, it's not that fantastic. So what do we do for medication? Well, I do a lot of co-treatment. So if I have somebody that has a lot of issues with pain or having tension-type migraines, I use a tricyclic antidepressant. Hold on, I bet I have something. No. First of all, Ambien, as an FYI, can and often has a paradoxical effect in people with brain injury. It is not quite enough that I put it on my fatigue slide, although I'd say I probably have about 20% of my patient population that use it for fatigue. That's how often. It will wake them up like nothing will. It can cause hallucinations. I have my gentleman that was able to inform me that you should not cook spinach in a waffle maker at night when you're sleeping. You will get great stories from it. Not the best for prescribing. When we look at that slide, when you remember that pie, that with sleep, sleep initiation and maintenance were issues, the problem is there aren't a lot of great medication that help with sustaining sleep. So that's the problem. Ambien just initiates sleep, so even people that can tolerate it and it works as it should will still come in with the complaints of waking up multiple times later that night. Lunesta is one that does work as far as sleep maintenance. There's an Ambien CR that supposedly will help with sleep maintenance. There are just tons of sleep medications out there. None of them are that great. So if you're getting to the point where somebody's left that you've done everything else on this list and they're still having issues with sleep, part of it's going to be time. Part of it's going to be increasing this and making sure they're actually following it. Because there is caffeine in more than just, coffee. Because I had a patient said, no, I got rid of coffee. But they were drinking sodas. And so just making sure that you're going through that. Also making sure that you're checking medically, endocrine dysfunction and so forth, just to make sure there isn't anything else adding to the pie. But sleep can be miserable if you've maximized everything. And like I said, I tend up using the tricyclic antidepressants a lot because they work very well for sleep initiation and maintenance. And most of my patients have some type of pain, something or the other. And I use it, and anyone that I have that has had more than one child, especially vaginal delivery, women that come in, they're like, I wake up 2 to 3 times to go urinate at night, and that's what's waking me up at night. It's fantastic because it decreases urination at night, so they'll be able to sleep through the night. For that reason, it's great for females. For that reason, it's not so great for men with any prostate diseases. So, something to keep in mind. But if you can get the sleep cycle reset and reset well, typically when there is a pattern of normal sleep and normal wakefulness, you can wean off of the medications. It's just a matter of getting there. And then mood. Again, it's kind of like sleep. You want to make sure that you're working on everything else first. You want to make sure that from a fatigue and cognitive standpoint, that's taken care of. You want to make sure that from a sleep and pain standpoint, that's taken care of. Because if somebody hasn't slept in 3 days, they're cranky. And it's not a mood disorder. And so, again, benzodiazepines, I cannot stress enough, just absolutely avoiding them at all, if at all possible. And then you're going to maximize treatment with multi-use medications. So things like Cymbalta, that work very well for pain management and can also help with mood. I like using medications that have a dual purpose. If it's something specifically for mood alone, patients that I have with PTSD and nightmares, prazosin works exceptionally well. So not only is that going to work well for them for their hypervigilance symptoms, they're going to be able to sleep at night because they're not having nightmares, and that will improve their mood. So I try to look and kind of cover combination treatments. And definitely assess for any comorbid drug or alcohol use, because that has a huge effect on mood, sometimes, in a pretty detrimental way. And then you can also look at other medications. There are benign medications that can hide and cause symptoms, like beta blockers have a very high rate of side effect for depression that doesn't really hit the normal population, the pre-TBI population, but then they're on the same medication post-TBI, and they're feeling the effects of that. So just to be aware. And so I listed some things up here. So, for instance, we mentioned before, Depakote, Class A evidence for migraine prevention. If I have somebody that has migraines and increased irritability, I have a medication that can work in two different arenas. Gabapentin, it's kind of a weakling when it comes to anxiety, but if you have somebody that's just mildly anxious, it actually does a great job. And we have enough studies to show that it can improve balance after a head injury that it's worth giving it a college try. Or if you have somebody that has diabetic neuropathy and they're having symptoms, that you try to treat more than one thing. But gabapentin actually has a pretty good effect across multiple spheres. The only problem is it's kind of low powered across multiple spheres. So if you have somebody that has more intense symptoms, it's not going to be that hot. Lamictal, again, you're looking at seizure disorders as well as some mood coverage. It works very well. I don't use it as often because I have so many people with migraines and it just doesn't cover it well that I'll look at the other medication classes before I will look at it. However, if there isn't a migraine history in there, but there's a lot of mood issues, especially in somebody who may have been bipolar previously, not controlled on their current meds, need a med switch, this is what I'll look at. Yes?
I missed the medication that you said decreased nightmares.
Prazosin, Prazosin. It's also called Minipress. And the folks over in Europe love oxycarbazepine. It does work very well with trigeminal neuralgia. They use it a lot for people that have cluster type headaches. Now, cluster type headaches are those ones that typically occur on one side of the head, and they don't last long, but they're the zingers. And they're intense, and they're short, and they're quick, and they occur multiple times. The zinger type headaches that are just really difficult to treat. And so they use this a lot over there because it can help treat that, as well as some mood disorders after brain injury. I don't use it as much because it is rather sedating. What I tend to use for cluster type headaches, it doesn't have great evidence, but we have enough to show that it can help, is 10 milligrams of melatonin at night. And that'll decrease the intensity and the frequency enough of it that I can typically get rid of the rest with doing nerve blocks. But just to put it on there for completeness because it is out there. And it also does manage seizures, so sometimes you can hit a few different birds with one stone. And then for mood, you have SSRIs, which are your typical Prozac, Zoloft. I was just mixing them together. They're kind of the same, all of the SSRIs. Then you have the SNRIs. Some of the more common ones are like Cymbalta and Effexor. I do not use Wellbutrin. Wellbutrin lowers seizure threshold enough that it concerns me that I just don't use it at all, even though it is the only one with basically no sexual side effects. But I've seen somebody who was 3 years out from their brain injury, started on it, that had a seizure. And I can find enough mood management with other things to not want to try that as my first line. I use the SNRIs quite a bit because they have coverage of multiple different things. So Cymbalta has coverage over pain, it has coverage over mood, and there's enough of a dopamine effect that if I'm using that with the mantidine, it'll actually improve cognition as well. So I use it quite a lot. Effexor is a good medication because it can also cover pain to some extent. Works very, very well for anxiety. It has a crappy, crappy withdrawal symptom. I mean, when you're trying to come off of that medicine, people just feel bad. So I typically don't start it. They come to me on it a lot of the times. I'll keep it going if it's working well for them. That's typically not one I jump to. The SSRIs work just very, very well for mood elevation. But if you have somebody that has very, very significant depressive symptoms, especially if they have a history of depression, sometimes they have to switch from one to another within that same class in order to have better coverage. Or sometimes they have to have the addition of another one. So it's something to keep in mind. And tricyclic antidepressants, again, are there for completeness. They do use these still a lot for depression over in the EU. We don't use them as much over here. Obviously, with TCAs, if you have a high enough dose, there is the overdose potential, and it's a point of no return with an overdose with TCA. And the thing to bring up with SSRIs, the one in that class that can do it too is Celexa. So that is the one SSRI people can get enough in their pill bottle to overdose on and will die from. So I try to avoid giving tons of medication that if I have a patient that's having a significant depressive episode with suicidal ideation, giving them an extra tool that they could possibly use before calling someone. And then the musculoskeletal piece, like we talked about before. Assess if you think that there's any component from the neck coming in, you can send for imaging, but more often than not, these are going to be those vague, reversal of normal curvature, and people are like, well, what do I do with that? There's only so much Flexeril in the world I'm going to give to somebody. What do you do with this reversal of the normal curvature of the C-spine? Well, but this is something that actually does need to be cared for, but there are people that know how to do it. And so a lot of referrals, physical therapy, and these are some of the things you're going to be learning with Marie. Very important things. Chiropractic therapy can be very beneficial. Trigger point management is huge, huge, huge. We have naturopath, osteopaths, acupuncturists in the area who do a great job. Massage therapists, I forgot to put them in. We have a couple that do myofascial specific techniques that work very, very well. And then pain management. We have some pain management physicians who are doing extraordinary things here. I work a lot with some pain management physicians who do prolotherapy to help with reestablishing some of the instability that can occur after these whiplash type injuries. There are a couple that are doing some interesting things with like stem cell injections and so forth. So there are things that can be done to help reduce the symptoms from the cervical spine. It's just a matter of actually having the willingness to refer the patient out into that system, or being the one to push and say, hey, I want the referral. And then teaching the appropriate stretching and exercise. And again, that's going to come from the person who's actually providing that treatment. And so, for instance, I do trigger point injections in my office. I'm showing people how to do the stretches to stretch out that area, because without the stretching after the trigger point management, it really doesn't do much. So it's kind of like an entire spectrum. And so it's just a matter of making sure that people have the education. You just can't do one treatment and expect for everything to be completely resolved. It's a continuation. And then for musculoskeletal issues, again, we talked about how, anti-inflammatories, the short-acting, add toward your 8 days per month if you're a headache person that you're worried about, medication overuse headache. I really like to avoid opiates, not necessarily because we have any studies showing that it delays healing or does anything particular for people that have had concussion, but because there are cognitive effects with opiates, and it's a short-acting medication. And a lot of the times they're given, and maybe not necessarily appropriate for what's going on. Because if somebody's having pain because they're having an acute muscle spasm, opiates don't take care of that pain. And so people come in and they'll be like, well, yeah, they gave me Percocet, but it really doesn't do much of anything other than make me sick to my stomach. But you give them something to help with their acute spasm, and they're like, oh, what a relief, that's what did it. So if you're looking at the underlying kind of muscle complex and you've taken care of trigger points and so forth, and you're just looking at somebody that has a continuation, just a lot of spasms, there's some things there. I didn't list Valium because it's a benzodiazepine. Do I have patients given Valium for their muscle spasms? Do I switch it over as soon as they come into the office? Because they're like, no, I'm not on anything for anxiety, but my doctor gave me this because it helps with my muscle spasm. I'm using it about 3 times a day, 10 milligrams of Valium. So, it comes from, all different sources. Tizanidine or Xanaflex works very, very well. It works for muscle spasm. It also works very well as needed for anxiety. And so when I talk about medicines I like to double up on, this is kind of one of them too. Because if I have somebody, and it doesn't work for true panic attacks, but it will work for anxiety attacks. And so I'll give them the tizanidine and I'm like, you can use this as needed for either muscle spasm or anxiety. And if it can keep them away from their benzodiazepine, that is the best thing ever. Baclofen, I typically use this in somebody that has true issues with tone. So can a person that previously had a stroke and spasticity have a concussion? Yes, it happens. And so I'll have people that, are on baclofen because they have tone issues from a previous, insult to the brain that have had a concussion on top of it. And so that's why I add things like baclofen and botulinum toxin to this list, because sometimes those are being used because you're seeing patients with a concussion on top of a previous stroke or cerebral palsy or some other type of underlying neurologic condition that led to having spasticity and probably increased their risk for falls, which is why they're in your clinic. So tizanidine is the one that I'll most likely use for people when they come in and they have no other issues or complaints beyond the concussion that they have. But I don't give it to everyone. I don't think that muscle relaxants are something that need to be just kind of like thrown out like candy. But I will use it if they're in the middle of a treatment program because it can help them to be able to tolerate it. And then the vestibular treatment. Really, the treatment is therapy. Vision therapy, vestibular physical therapy, that's the treatment. The medications are not long-term because they will suppress the vestibular system long-term, and that's not a good thing. However, will I give somebody meclizine so that when they go for their first appointment, they don't quit because they threw up on their shoes on the way home? Absolutely. And so I'll be like, here's your meclizine. Take it to your appointment. Trust me. And they do. And so we use it for short term just until they can feel better enough that they're doing the therapies and not having the symptoms. Do I have patients long term with concussions that they're like, oh yes, I'm going on a cruise? And we're like, alrighty then, here's your medicine. Yes, absolutely. Because they'll have an increased sensitivity to their system even if they've had treatment. And so I'll use scopolamine patches as well. I rarely use diamond hydrogenate because it will, you see one of the side effects for scopolamine is dizziness. That's not as much as, diamond hydrogenate will make them feel even more dizzy than they were before they took it. So I typically don't use that medication a lot. Really the two that I tend to use are meclizine, and that's just short term to get them through starting with their therapies. Or I'll use scopolamine if they have something coming up that they need to go in or go on a cruise or whatever. Or I'll use it in people that just can't tolerate even the lowest dose of meclizine because it just knocks them out. They're like, well, therapy would have been great if I wasn't sleeping. I'm like, oh, we'll try this instead. But they're not for long-term use. And I have had a couple patients that have come in and they're like, well, I've been taking this for 2 years and it just doesn't seem to do anything. The treatment is the therapy. This is just kind of to help guide the symptoms while they're getting started. And then, the biggest thing are referrals. Referrals. getting people out into the system, getting them involved in the treatments that they need. There's not one practitioner that is going to be providing all of the answers and all of the treatment to somebody that's coming in with a concussion. It is your brain. It does a whole bunch of different things. It needs a team of people working with kind of like this multidisciplinary approach to help somebody to feel better, including the person who's trying to get better, because they have an active role. Diet, exercise, the things they're doing at home. It's the entire team working together on it. It's very frustrating when you're dealing in a system where people don't want to put out referrals. Because I'm like, you need to get the referrals out there. And so, I'm like putting, put pressure on the providers to do that. Make sure they're getting people, make sure that they're getting people out into the treatment, because it's the treatment that actually takes care of it. There's only so much brain rest you can do before at some point somebody's got to say, well, maybe we should treat them. And I'm hoping with the screening tools that process occurs sooner rather than later. But definitely getting the referrals out there and getting people involved in the services that they need, that is what's actually helping somebody to heal from their brain injury. I list laboratory studies in here because I think it is important to know that there's more and more information coming out that even after just, a mild traumatic brain injury, you can have some pretty significant endocrine abnormalities. And so we're looking for those, testing for those, and treating those. For right now, most of the stuff that we have that is in print is looking at people with more significant brain injuries, but we're looking more and more now toward the mild traumatic brain injury side. We know that sex hormones can be off, both male and female. So testosterone, the luteinizing hormone, follicular stimulating hormone, estrogens, those are things that I check. We know that the thyroid can be off, or there can be issues with the thyroid with the pituitary adrenal axis. So it may not be that the thyroid is the issue, but it may be that the pituitary gland is not stimulating the thyroid enough for it to produce effectively. So these are laboratory studies that we're looking at. That being said, what are we treating them with? Well, if it's thyroid, if it's pretty cut and dry, we can replace thyroid. If it's testosterone, we have enough research now that we know that we should be bringing their thyroid levels up to normal. And so we're using either, what we did at Walter Reed was with the oral medication. What's coming out recently has been more with the gel. But when it comes to replacing things like growth hormone or some things like with the pituitary axis, there isn't that much out there. So a lot of what we're going through, we're doing from a more natural standpoint. So I work with Dr. Grove a lot, who's the naturopath that spoke to you guys earlier today, because we do have some supplementation that, we've had patients just say, I feel better, I am doing well on this treatment, and so they're continuing on. As far as actual studies coming out looking at those, they are on their way, but we don't have any specific answers to that yet. Yes.
So you have a gentleman who has had an accident, definitely TBI, was not diagnosed, was a male and is now a female. So what do you do for her, the wife? I mean, and he has that, this is just me. And he has gone to everybody, hearing, well, not hearing, which is to you. So who can, the wife, they went to Seattle. They're saying that's just him now.
Well, there's another piece to the puzzle that is really hard to define, and that is, and it goes beyond mood. There are quite a few patients with mild brain injury or above that they will look and they will honestly look at a picture of themselves from before and say, I just do not know who that person is. And it is a complete and utter personality change, and you will hear it from the family. They will say, I just don't know the person that they are now. That is not this is a new person that I'm living with. And you will hear it from the patient when they say, I'm not that person, and I don't know if I'd want to be that person or I'm not that person, and I don't know how to get back to being that person. And I will tell you, that is one of the most difficult things to treat that we have at this point. Now, there are some programs down in the lower 48 that part of their focus is in trying to get people back to where they feel like they're back to themselves. but they're very few and far between, and they only accept private insurance because Medicare and Medicaid will not pay for them because they do not see the benefit in helping somebody to return to their previous personality as long as they're functional. I mean, it's a sad bottom line. But it is very, very much a piece of that. And so, yes, you can have endocrine abnormalities, but if the person is cognizant of their medical choices and chooses not to do it, or chooses to go in a direction to change genders, there is really nothing as a provider that you would do other than providing the input that if they had any questions or if they needed any follow-up, make sure that they had the appropriate medical follow-up to cover them for that. And if there's somebody who looks at a picture and says, I don't know who that person is, and I don't want to be that person, that is their right. And if they look at that picture and they say, I don't know who that person is, and I want to be that person, then we do our best to try to get them involved in a network that can help with that. But it happens more often than people really want to, kind of put the spotlight on, I think is the best way to put it. Because, back in the day, everyone was like, well, we expect this with severe brain injury, We know this is going to happen. Somebody with a severe brain injury, we know that there can be significant personality changes. But we're seeing this now, it's become more recognized as part of the phenomenon that can occur with some of our more mild brain injuries. And we didn't have great treatment for it with the severe. We don't have great treatment for it for the mild. And it's hard to get that treatment going when you can't provide the research, when no one wants to pay for the treatment anyway. Now, if it's a matter of somebody does not want to check the sex changes that can occur with the endocrine abnormalities, definitely they need to be treated. We do not have a neuroendocrinologist up here. I end up using the Swedish Pituitary Center. They have a neuroendocrinologist that's pretty specific and does a lot of work with some of the derangements that can occur in the pituitary adrenal axis after brain injury. So Swedish is pretty good with that. But if a person does not want to have the treatment, or if they choose to go with treatments that would be gender change treatments, and they have the cognitive abilities to do that, that is within their right.
But what if, this is what's so sad, was that he did not. But because everyone he went to, all of the help he went to, they said, there's nothing wrong with them. But he kept saying, there's something wrong with me, and I know it, and I want,
Right.
And they couldn't,
And the unfortunate part about Alaska is you may not have all the subspecialist stuff here. And so you will get a lot of people walking into your office that have been grossly mismanaged for years. And I've seen it a lot. And the best that you can do is try to get them into the appropriate resources they should have been in the first place. But I will tell you that there will be improvements. And so that's the one kind of caveat that I put out there is don't think because it's 2, 3, 4 years post that you cannot have significant improvements. You can. It just takes a little bit longer, but it's there. And so it's worth getting things started and getting people put in the right direction. And that's why we do these educational series like we do, because the more people that are aware that these resources are out there, the hope is that somebody will run into one person who has been at one of these conferences who can say, you know what, I've heard about this, and here's where you can get the information, or here's the information that you need so that you can move on to the next step in your treatment and at least get started with it. Because getting started with it is the most important piece. It doesn't matter the timing, although sooner, of course, is better than later. Any other questions? Yes.
If somebody's never had a seizure and then has a head injury, what's the chance of them having seizures after the head injury?
So with mild traumatic brain injury?
Yeah.
So I do have, and this is kind of going out into areas that we have not really studied well at this point. But I will tell you from having a practice devoted solely to head injury, I have people that have new onset seizure disorders after mild traumatic brain injury. I have people that have new onset hallucinations from mild traumatic brain injury. Perfectly normal scans, but they're there. And you'll see weird, like I have somebody that I just saw that it was just a very atypical presentation of hallucinations that led them to me. Because somebody who had been at a training was savvy enough to recognize, hey, you know, a 50-year-old shouldn't have new onset hallucinations without anything else in their life going on other than they were involved in 2 motor vehicle accidents with concussions. And these aren't typical hallucinations. And then, you know, that's when you look, are these kind of, and unfortunately some of the seizures that I'm seeing are these deep frontal seizures that don't pop up on an EEG anyway. So you're treating, and then they come in and they're like, well, I've been on Haldol, Zyprexa, Rivermead, and nothing works. And then we give them a seizure medication and it works. You know, and so you can get these atypical and very strange presentations. They don't happen often. I don't have a number to give you because we really don't have any numbers written down, because that's just something that is now starting to be recognized as, yes, this can be part of it.
So if we treat patients, we should be aware that that could be.
Just be aware that it can be there. Yes.
With professional and competitive athletes, you hear that if you have multiple concussions, that's a terrible thing. And when do
CTE.
you stop? I mean, 1, 2, what's the limit?
We will talk about that here shortly. Yes.
You mentioned atypical headaches
Yes.
or migraines.
Yes.
Can you go into a little bit more about that?
So atypical migraines, specifically you need to be kind of on the lookout. You're not going to have somebody complaining of headache pain or migraine pain. You're going to have these vague complaints that you're not going to really know kind of where to put them. And so I've had people come in and they're like, you know, I try to get up and walk around, but I just get these waves of dizziness that flow over me. And I just really can't even walk down a straight line. And especially if they're like, wow, and that carpet. And trust me, we had an insult to the carpet outside my office and it was changed to that carpet. I said, it's kind of like the gauntlet. If you can make it here, you've done so well. But, you know, you'll have these kind of off symptoms, or they won't be progressing very well in their vestibular therapy. And then you're looking for, and they kind of come and go. They're these spells that kind of come and go. These are some of the presentations that can come in for atypical migraine. They can, you know, it's just, and it's very important to treat it because they won't improve with therapy alone if it's not. And so keep in mind that that is very, very common after head injury for these atypical migraine variants that are pain-free or relatively painless, but they're having more of the spells of the other prodromal complaints that are occurring more frequently that are delaying their recovery. The other piece too, and I don't know why I didn't put it up here, is ENT. Because there can be some peripheral effects that can occur after a mild traumatic brain injury that can also worsen vestibular issues, such as, you know, traumatic perilymphatic fistulas. And so referrals to ENT are also important. But just like kind of any other physician specialty, not all ENTs kind of look specifically for that. But we do have specific ENTs that's kind of part of their clinical practice. So again, you know, using your referral network, and that's part of what we tried to do with the Alaska Brain Injury Network so that everybody would have one source shop to know where to go to look for the people that are doing these particular things for the state. And that's why it's so important as people are recognized and as people are doing trainings that either you know them or you are that person, that you get in touch with them so that you can be on the list. Because that's the best way to continue to make sure you know what resources are there. Yes?
What about treatment for pediatrics?
So pediatrics. That's difficult up here because we do not have a pediatric neurologist that specifically deals with brain injury. I've had a lot of kids that their parents were just waiting for them to turn 14 to bring them to the right clinic. A lot that had just flew down to the lower 48. If you go to the website for the American Board of Physical Medicine and Rehabilitation, there is a place that you can click on to locate a subspecialty, and you can click on brain injury medicine, and then you just go by state and you can find out who's there by state. The unfortunate piece is, on that list, you can't tell what all their subspecialties are. You have to click on each individual name, but that's okay because there's only like 300 of us. So you click on the name, and if you see that they have a subspecialty of both pediatrics and brain injury, then you know you've got the right person. But there, as little of us as there are even fewer of those. And so what we've been trying to do, there is a specific, the International Brain Injury Association, we meet every 2 years. There's a Pediatric International Brain Injury Association that also meets. They just met in Liverpool. And so it's trying to get that information out to primary pediatricians, as well as to pediatric neurologists. And you don't have a pediatric physiatrist out here. So we've just been trying to get the information out to the pediatric clinics. Yes.
It's not going to work for everybody, but if you have a child who has brain injury, if they have insurance that will let them, if you go to the University of Washington Seattle Children's Hospital, they have an outreach clinic that they do that follows their own patients about 4 times a year, and they'll see their own patients. So oftentimes I'll encourage them, go to Seattle Children, and it's purely for the follow-up care. So put into their system and they'll see them. And it's everything, spinal cord, brain injury, any kid that went through Seattle Children that lives in Alaska, they are now doing these clinics.
And other clinics are being built where they're trying to do telehealth. I know a friend of mine, she works at the university, she works down at the Children's Hospital in Cincinnati, and she's one of the few dual-boarded pediatric as well as brain injury. And so they're trying to get together with the other groups to kind of form a network so that they can at least put out some specific educational material on that piece, and then try to do some of the physician education as well, because it is difficult for travel. So they're trying to get that out there. I'm adult only, so unfortunately I can't help you any more than that. But the pediatric piece is working its way through as well. Yes.
For me, it's kind of hard to hear you guys on the other side of the room when you ask questions. I don't know.
I'll repeat.
You guys are having trouble hearing us.
It was the question about pediatric brain injury, and so unfortunately, again, there are very few providers that specialize 100% in that, but there are providers that have quite a bit of knowledge about it, and so they're working on trying to coordinate that and pull that together. But it is a complete, I mean, not completely different, but it is a complete, it's a different paradigm for treatment for kids versus adults. Yes.
I just wanted to refer to you. I'm a nurse in a high school setting. I have a kid that came back literally 3 weeks ago with paper from his care provider that said, I don't deal with brain injuries or concussions. Return to play is normal.
Okay.
That helped him
Oh. So the state of Alaska does have guidelines for being able to clear for return to play. You're supposed to be doing the CME provided on the CDC's website for sports return to play, as well as 2 additional hours of brain injury specific CME before you're clearing a kid for playing sports. And that's the reason.
Yeah.
So I am, unfortunately, due to a family emergency, having to leave the state in December. The 2 practices that are going to kind of be taking the follow-up for my patients, if it's more significant head injury and they're in Anchorage, Peak Neurology will do it. But all concussions, because they're pretty saturated already. All concussions, regardless of Anchorage or not. And then anyone, of course, in the Valley would be going to the Alaska Brain Center with Dr. Spotsler and his crew. Those are the 2 that have, I've directly spoken to as far as, will you please do this? And they've said yes. Yes, yes. And like we talked about, you're working on the most debilitating symptoms first, headache, sleep, and mood. And I'm going to be I'm kind of flipping back and forth here a little bit because I was going to talk a little bit about the imaging. And while I'm pulling that up, I'm going to talk about CTE, which was brought up as far as a question because that is a big deal. And it is very, very concerning. So I don't know how many of you are familiar with the story of how this is going, how this started. It's coming out in a movie. Will Smith. Watch the movie. I don't know. I've seen the previews. The previews look good. I'm just glad because the awareness, it just heightens the awareness even more. But chronic traumatic encephalopathy, that term came out relatively recently, and it's been the product of a series of investigations into some of the NFL players who committed suicide and then did it in such a way to keep their brains intact and ask their families to please make somebody look at this. And I was working in DC and working with, when you're in DC, you work with everybody. You're kind of like, that's just the way it is. And so the complexes all work together. And so, especially with brain injury, we were a tight-knit group. And so when Junior Seau's brain was being autopsied, I was there. And it was a big deal. I mean, it's a big deal. You'll see it in the movie. It's a big deal with the NFL because the owners were fighting for any information to be put out to the public. It was a big deal in the military because they were like, the results of this have very significant consequences for all of our soldiers, sailors, and airmen who have been exposed to multiple blast injuries while they've been in theater. This was a big deal. And what they found when they did some of the initial autopsies for these athletes that had sustained multiple hits, they're having non-reversible anatomic changes to their brain that they assume, and it's pretty, direct correlation to the trauma that they sustained. And so they have basically patches that are found, the fibers that are found within the brain that are creating it are similar to what is seen in Alzheimer's dementia, but the location in the brain and the pattern that you see in chronic traumatic encephalopathy is different in Alzheimer's. So it is a very different entity. There was no way of looking and saying, well, these are people that would have just developed Alzheimer's. This is just early changes. It's occurring in different areas of the brain. And so that started the ball rolling. And that really started looking at these players that came in that were having continued symptoms. That started the whole ball toward looking at, concussions can cause these continued symptoms. And they can be severe and significant. This is not something that you can just brush off and saying, based on data you had 15 years ago that no, this could not be from a concussion, people feel from a concussion. It changed the entire thought process for how we look at and treat brain injury, specifically mild traumatic brain injury. So that being said, what's new? We do not know how many hits it takes to develop chronic traumatic encephalopathy, and it appears to be player dependent. And we are fairly certain that it does not need to be involved in sports because the brain does not care if it's from sports or from non-sports concussions or from blast injuries. You're going to get chronic changes that occur after multiple hits. There is an aspect of resiliency of the brain that is very individual. And so there are some people that have had multiple hits that of course we don't know they don't have changes because they're still living, and right now the only way we can see the changes are post-mortem. They're still working on trying to get the protocols together for us to be able to see them with imaging. But we do know for those that have had symptoms and that we've done studies on and looked at their brains, We've had people that have had multiple hits, over a dozen. And we have a group in Canada that have found changes with the brain slices and athletes that have had less than 3 hits. So we don't know. We don't know how many hits it'll take. So that being said, kind of the guidance is the less hits the better, because we really don't know the number. In children younger than 12, because they have less developed neck musculature, you're going to be more conservative. We don't have any imaging studies to show it starting, and we don't know the number that it'll take to get there. And so there's no guidance as far as if you've had this many, you're out. That is, that has remained pretty practitioner dependent. I will tell you from my standpoint, if I have a kid coming in and I'm looking at them and they are on their 3rd hit and they are not healing quickly, I tell them from that point, no more contact sports. And I include soccer in that, because my worst patients are my soccer players and my hockey players, much more than football. I have a really hard time getting soccer players and hockey players to heal. And I think, again, it's because of the neck piece. But thankfully, due to all of the education that's been out there from the Players Association, kids are more likely to do it. And parents are more likely to back you up with it. When we were saying this even 5 years ago, the parents went nuts. They went nuts because little Johnny's going to get a football scholarship and this is going to pay for his college. And I'm like, but if he can't go to college because he has no cognitive capacity left, that's a problem. And I've had more than one athlete come into my office that said, I'm afraid I'm not going to be able to go to college because of the way my thinking is. And we've been able to do it, but sometimes you're not. And that's a scary process when you're looking at 15 and 16-year-old kids. So I tend to be very conservative because I feel, you have a lot of life ahead of you. You don't need to be damaging your brain at this point. So that's kind of the bottom line. We're still working on it. So yes.
So, just kind of a question here. With all the drug problems we have in this country, how much of it do you think is self-medication from brain injury?
Obviously, there's a lot of self-medication from even just more than brain injury. Access to adequate behavioral health services is also lacking in quite a few areas. And so there are a lot of people that will be using, drugs and alcohol to manage symptoms. And so that being said, you can't work on a remission program without identifying other factors that would be involved. And so when we look at like the screening tools, for instance, part of where we're getting them out to, other than just, working with the health aides and working within, I have quite a few schools that are using them, but also working in the prison system, also working with drug and alcohol system, because, if you can identify an underlying source that would have led to the symptoms that are being used as a basis for self-medication, then you can start the treatment for the underlying source. But yes, I see a lot of patients that come in that have been using various and sundry to just try to keep things down. And I'll tell you, there are things that you think of, like alcohol, you think of different drugs, and then there are things you don't think of, like my patients that are having, a lot of hallucinations that are smoking like 3 packs a day, because nicotine does decrease hallucinations. So, substance abuse across the board. So as far as imaging studies are concerned, we have some things that are on the horizon, one of which is diffusion tensor imaging, and quite a few people have heard about that. These are things that we're trying to design to specifically detect changes that can occur with mild traumatic brain injury that we were not able to get to before on standard imaging. And so what diffusion tensor imaging does is if you look at the pictures, they're actually pretty beautiful, and these are the ones that you've seen where you can see all the pretty nerves and fibers of the brain if you look on the internet. They're just gorgeous. But you can see it's looking at specifically at identifying the white matter tracts that are occurring. And so where that's important is we know that the changes that occur with mild traumatic brain injury occur in the deep white matter of the brain. So white tracts. So we're identifying the integrity of the white tracts of the brain, and we're trying to basically match people who have had mild traumatic brain injury versus normals, i.e. those without, to determine if there are any changes in the size of the tract itself, if there's been any type of loss. And we do know that loss can occur. Do we have enough specifically that we're using this in everyday clinical practice? No. Because you have to figure you need a whole lot of normal people for comparison to know exactly what that bell-shaped curve is as abnormal. And the unfortunate piece with this is that, you know, there is some sensitivity with people that really do have a great deal of changes. And there are some people that are going to have symptoms with no changes even on the diffuse or tensor imaging, but it doesn't mean that it's not there. Some more images, again, just showing the tracks, and that's basically what this imaging is trying to do. And you can really even tease out and pull out some specific tract areas so that you can look at, there are different measurable variances that you can look at to kind of look in specific areas of the brain and compare your person to somebody in the kind of quote-unquote normals group. Now, we're working research-wise on this. There are some places that are doing it so that we can help build up the numbers. We're not using it as much in just standard clinical practice as of yet, but we will be shortly. This is something that is going to be one of those right around the bend type of things. Are bad lawyers using this? Oh, yes. Oh, yes. Because, you know, when we do the North American Brain Injury Society conference, the legal conference is right next to it. And sometimes a group of us will just go sit there and listen and chuckle. It's kind of like Mystery Science Theater 3000, because you're listening to them talk about all of these medical terms and throwing them out there like, well, yeah, the FA was da-da-da-da-da-da. They have no idea what they're talking about. I mean, it is completely different on a legal standpoint, so if you hear somebody spouting off numbers from a legal standpoint, that has no clinical significance whatsoever. Just letting you know. Same thing with functional MRI. We do have some great, studies that are occurring looking at functional MRI. We know that the brain actually does have decreased energy production, energy capacity after mild traumatic brain injury. Again, not something we're using in our standard clinical practice as of yet, but it's starting to pop up in some of the larger medical centers as add-ons for what they're doing as we're building up cases to really put out, this is what the protocol should be for just standard clinical practice. MR spectroscopy is another one, and this is it's still in research production. This is the one that we're trying to bring into up here. Because when I say research production, a lot of insurances won't pay for it as part of clinical care, but if we're doing research production and we're getting MRIs on people anyway, we can add these on under the research type grants to kind of not only use it for clinical benefit for the future as far as adding to, our knowledge of what's going on, but we can also, I have a lot of patients up here like, hey, I would like to feel that I'm making a difference somehow in the overall education for people in the future, and this is a big deal. This is a big deal for people that walk in. What MR spectroscopy does is it measures different amino acids and different chemicals in the brain, and we can actually follow these over time and watch for improvement, and it's really sensitive, which is great because it'll pick up some of those people that nothing else has picked them up, and so it'll pick up the changes and the differences in their levels, whereas maybe their other like DTI scanning and so forth look normal. So it's pretty sensitive. It'll pick up those changes pretty immediately, and we can follow it over time to watch the progression of healing, which is very nice. So this is one we're hoping to get up here shortly as part of our research protocol. We're doing this one now, susceptibility weighted imaging. It is part of the standard brain injury MRI that's occurring I'll tell you, the 2 scanners that are doing it, it needs to be done on a 3 Tesla scanner. They're doing it at the one here in Anchorage at Providence Hospital, and in the Valley, they're doing it at the Advanced Imaging Associates something. The one that's down by Matsu Regional Hospital, that one, they pulled out the 3T and they're doing it there. We have a neuroradiologist who just moved to Alaska who is brain injury specific. You know him from the old work on the Players Association. And so he's doing the reads for those brain injury protocols that are being done. And we're trying to expand that out. This is very, very sensitive for some of the tiny remains of blood products that you can see after shear injuries and high velocity accidents that you do not pick up on a normal MRI. Yes.
Who's that neurologist?
Jerry, the neuroradiologist is it's Jerry York.
Jerry York.
Mm-hmm. So we're doing the SWI. We're also doing volumetric studies because we do, and I don't think I have any pictures of the volumetric studies, because we do know that there can be decreases in volume in certain areas of the brain, especially in the white matter, as well as some in the frontal lobes that can occur after mild traumatic brain injury. And so we are doing the volumetric studies as well, like we were doing with the Players Association when we're doing the brain injury protocols now here in Alaska. So those are 2 things that have been added on. Yes?
But we're not doing the diffusion tensor imaging.
Not yet.
Where is that being done?
I know UCLA is doing a lot of them. I think probably they're doing some of them in Washington. I mean, since we're really not using them for any clinical practice purposes, I'm not sure as far as who's. I came from the East Coast. I know where the East Coast people are doing them, but I do know they're doing them down at UCLA as well. But I think the next thing we're going to be pulling up again, I think, is going to be the MR spectroscopy, because that's just shown. My buddy's the physicist over at NIH, and he was like, he's pulling his hair out. He's like, I'm so tired of ETI. I'm just going with MR spectroscopy from now on, because it just shows so much more. And then we met with the physicist from Harvard, and he's like, yeah, MR spectroscopy, it just seems so great. And I'm like, well, you guys just need to make sure we're checking the same areas so they can put a standardized protocol out so that we can all be doing the same thing. So that'll be the next thing coming up. Right now with DTI, you've got a whole bunch of cowboys doing all sorts of stuff and checking different things, which is how the legal system loves it. Because, man, you give somebody a bunch of numbers, they can make it work in pretty much any way they want to. And so until there's a good standardized protocol out, you're comparing apples to oranges, apples to oranges, apples to oranges. But with the MR spectroscopy, since it's going to be really tight and it's going to be the same, we're using the same kind of diagnostics around the board, that'll be much easier for comparison. And then, PET studies, again, have not really shown anything exceptional with mild brain injury, but we're going to be starting to use them a little bit more with the spectroscopy so that we can kind of use them kind of like as a guide. So a lot of these things that you're seeing are kind of layered together in the research protocols now. Trying to pick them apart as far as clinical significance, as far as what they would do individually, is not really, been shown as of yet. So I'd say the biggest thing, well, SWI is here now. So you have that. The MR spectroscopy is going to be next on the list. And DTI, if they can ever get, just a standardized, like this is going to be the protocol out there. We'll be pulling that up. It'll probably be the same one that the DoD uses. We were working on that over. It was kind of like a joint DoD and NIH project. Anyway, it'll probably be that same one. And we talked about the common issues. And I believe that is the end. If there's any questions or anything that I didn't touch on, please, feel free to bring it up or let me know if you have any questions. Yes?
I have a couple questions. My background's critical care, and so, of course, these weren't mild injuries, but I just was going to ask about, you're talking pretty much about brain injury as well as physical kind of trauma. What about the encephalitis and encephalopathies and
Absolutely.
viral?
Yeah, absolutely. Acquired brain injury is the other half of what I see. And so you can get it from a variety of different things. You can get it from encephalopathies, you can get it from inflammation, you can get it from infection, metabolic disturbances that can occur like end-stage renal disease and so forth. Anoxic injuries are very common after cardiac arrest. And you can also get it from things such as metastases to the brain or primary tumors of the brain. You can also get it from nothing to do with the brain, but you're using chemotherapeutic agents that affect the brain. So I'll see a lot of people in my clinic that have had various types of cancer, have been on chemotherapeutic and have basically quote-unquote chemo brain. We'll do treatment for that as well. So a lot of these treatments do cross over. I also, and there's a lot more research being done as far as chronic trauma. And this is not trauma to the head. We're looking at people who have been victims of trauma, especially starting in their childhood, for a sustained number of years, have anatomic differences in their brain similar to what we see in brain injury without having blows to the head. And so they will have cognitive issues, some of the same issues that we're seeing, even without any forces to the head. So that's the next arena that they're looking at. We're working with, there's a group that specializes just with, the trauma medicine, especially like from the domestic violence, sexual abuse and so forth. So that's part of the pieces that are being put together now as well. But the treatments cross over.
And then one other part of the question, just in my critical care experience, we've used benzodiazepines, and what about our patients?
I know.
So is that something that...
So I just sat down, at least here at Providence, with the critical care team, ICU team, neurology, and so forth, and we standardized kind of some general treatment guidelines for the floors, as well as for the units. So one of them was no benzos. One of them was no, because you notice we didn't talk about atypical antipsychotics because it's a little bit beyond the scope for just, general brain injury management. That goes a lot more into the sphere of mental health, but a lot of the times you were getting, antipsychotics that were scheduled to help deal with the patient's agitation and behavior. And so part of it was, you can do PRN, you can do as needed, if there are issues with aggression. However, it is not to be scheduled unless you clear it with either somebody from behavioral health or neurology. So there are going to be guidelines that are going to be put in place here. And of course at St. Elias as well, we've been doing them because we've been working over there. And the hope is that since the hospitalist teams cover both here as well as regional, that there will be some crossover with that. But if there are any hospital administrators or anybody who knows hospital administrators that would like to get the finished protocol, you can definitely get in touch with me and, would be happy to share. But it's pretty much a standardized, it's considered standard of care for people with head injury or even stroke in the units and in the hospital, what they should be receiving and not receiving.
Is that crossed over the Peds ICU too?
I just met with them last week because I was like, hey guys, we gotta do this now. Okay. So we just had it written up and it's going to be put in because we're doing it with the Rancho Los Amigos scale. So we're putting it in with that, which basically looks at all of the different levels of somebody who is kind of returning and healing from a brain injury. And so like the first three are like different levels, decreased level of consciousness at different types of levels. Some are agitated and confused, some are non-agitated but confused, and so forth. It goes through the entire spectrum. And so we're putting it together as a full packet for not only, physician education as far as what to give and not give while in the hospital, but also making it up as a packet for family information so that they know here are some of the environmental things you should make sure are occurring when your loved one is at this level, because they're the best ones to police, anybody coming in from, housekeeping or whatever, or, somebody who's just covering and turning on a television and they're like, hey, no, that needs to be off. This is their quiet time. So we're, crossing the boards. It's not just, for providers, but also for family education. So as soon as that's done, it'll be disseminated. Yes.
Is there any guidance on help for the nurse, for the physician, when your patient is aggressive and violent? How do you, are there tools out there to help you? Because I'll admit, I have been beaten, I've been hit, I've had my glasses broken, and I'm darn scared to go near them when
Yeah.
they're like that. But I think I just need the tools.
Yeah. And so part of what we put together was starting the agitation management early. Because if you get it started early in the unit, it actually improves their overall outcome. The other piece, and part of that is not just medication management, but part of it is due to some of the new research we found that if you have males that have low testosterone and you do not replace it, they are more agitated than males who have had low testosterone post-injury that do have it replaced. So part of it is going to be testosterone replacement, part of it is going to be starting the correct medication management, part of it is going to be doing complete, correct sedation protocols and weaning protocols from sedation, especially in people coming in with alcohol on board. The other piece of it too is we're trying to pull up, there are groups that teach how to manage aggressive patients in a safe manner for staff, and pulling up one of those groups in order to teach. There are a few of them around. I know we have our own group that we built over at National Rehab Hospital. We would just go around and teach how to do kind of just, simple but effective maneuvers to keep yourself safe, to keep your staff safe in the event that somebody would become violent. So those are out there. Yes.
You mentioned, or someone mentioned, that family members who tend to be overlooked in this. For moderate to severe TBI, I just want to mention a resource. You can't download it for a site. It's a big, thick binder, but a hard copy can be ordered for free.
What's it called?
Mailed. It's called It's called Caregiver's Guide for Moderate and Severe TBI, and it leads the family member or caregiver through, definitions they might encounter, through different types of healthcare professionals, tips in working with the
Caregiver's
family
Guide
member
from-
when they come home. The injured person is very comprehensive.
A caregiver's guide to moderate and severe TBI.
And you can order it from the website, which is the top of that whiteboard over there. That's our website.
So the DivBID website.
Yeah, the DivBID website.
So, and that's, and really the families being involved, or that's a key piece, especially in more significant head injury. And so they're part of the team. It's just a matter of the way that we work. And so we've been doing it quite a bit, and it has some really good results. And so we're just making sure that this is kind of more standardized and in place here soon. Yes.
Click on that. Is that a free book? Is it a free guide download?
It's a physical book, correct?
It's a binder, and it's so large that you can't download it. You can order a hard copy though, and it's free. It's
Yeah.
free. Even if you're not military, or if you're not DOD or VA affiliated, civilian providers and families can order all these materials for free.
And let me tell you, the DivBID site is super, super helpful, because a lot of the handouts and a lot of the things that they give for some of the issues that occur post-TBI are not military specific. And people will find them very, very beneficial. There's a lot of educational information on there. And I know, they were like one of the first crew to put together when we were looking at kind of treatment paradigms and how we were going to look at treating different issues that came up after brain injury. They were one of the first to put down, yes, vision therapy is needed. And that made the government have to say, well, crap, now we got to pay for it. But, but that's, so there's some great information on the website. So I definitely recommend that you check it out, because it is not military specific, and just a lot of great information.
And Dr. Murphy,
Yes.
also, I mentioned it very briefly while I was giving my briefing, but people might not have picked up on it. Also at our site, and there should be dots between DivBID and DCO, I just didn't write them boldly enough, that there's a provider education and continuing education section where, and it's all free webinars, free internet-based training where you can earn CEU for certain specialties. So check it out.
Any other questions? Yes.
Yeah, you expressed how much you appreciate yoga
Yes.
recovery. How does that compare to Pilates?
So Pilates, what I like about yoga are a couple things that you don't necessarily get in a general Pilates class. Pilates does work very well for kind of just improving truncal supports and so forth, and improving your just overall core strengthening program. They tend to not have as much of the balance piece of it that the yoga does. It tends not to have as much of a balance between the stretching and the strengthening that the yoga does. But the biggest thing is it doesn't also incorporate and really emphasize the breathing piece as well as the meditation piece, which are both very important. And my patients just look at me. And I'll be like, when did you start your yoga program? Well, I didn't. Well, you know, to fix that problem like a while ago. All right, whatever. And then next, when did you start your yoga program? Well, I didn't. Well, it would fix that problem. Yeah, I know. And then like fifth visit, and it's like, they don't complain. I'm like, you started the yoga program. They're like, yes. And so, but it really does help, you know. So, but just don't expect it to be like, you know, people be like, oh yeah, I cannot wait to jump into doing a whole new exercise program because this is going to be fantastic. In meditation, I love doing nothing but sitting and trying to meditate for 15 minutes.
You should try seeing when we tell soldiers.
Yeah, that's even
Yoga,
better.
we have it
That's even better. You get the look.
Hi.
It's lunchtime.
I'm hungry.
She's hungry. So I will be here during the lunch hour for anyone that has questions. And again, any providers who are interested and willing to start with some of the prescribing practices, please find me so I can give you my cell so that you know you have support in doing so. Thank you.